Esteemed faculty and dear delegates, a very good evening to one and all. I, Dr. Tanmay Rane, feel privileged to welcome you all on behalf of the entire team at Emcure Pharmaceuticals. We at Emcure are proud to present Empower Talk, our highly anticipated scientific program dedicated to exploring the multifaceted landscape of diabetes management. This program serves as a bridge between knowledge and practical application aimed at equipping us with the tools needed to enhance the lives of patients affected with diabetes mellitus. Our distinguished speaker is poised to share her knowledge, insights, and practical wisdom to empower us in the fight against this health challenge. We are thankful to our speaker, Dr. Pramila Karla ma'am, who has generously decided to share her time and wisdom. Emcure is privileged to have a role in facilitating this bond. Let me have the privilege of introducing our esteemed speaker for this program. Dr. Pramila Karla, ma'am, is the professor and head of Department of Endocrinology, MS Ramaya Medical College and Memorial Hospital, Bangalore. She has graduated with honors in MBBS, won the Surat Kumari Lal Gold Medal for the best work in Department of Medicine, won the A.V. Gandhi Award for Excellence in Endocrinology for the year 2008. Ma'am is a member of prestigious societies like Endocrine Society of India, Indian Thyroid Society, RSSDI, ISBMR, KRSSDI, API, Endocrine Society, and also of prestigious societies internationally like AACE and ATA. She was also the executive committee member of KRSSDI for the year 2011 to 2012, executive member of the Indian Thyroid Society, member of the National Academy of Medical Sciences 2016, executive editor of the Thyroid Research and Practice. Ma'am has 70 scientific publications in national and international journals and 23 chapters in various books. Ma'am has also presented in national and international conferences. And finally, I would like to also extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. Let me now brief you on the agenda of the meeting. We will have the expert session on today's topic, followed by the Q&A. Therefore, I request the audience to post their questions in the comment box so that we can take up those questions. Without further ado, let's embark on this educational voyage together as we endeavor to enhance our understanding of diabetes management. I would now request our speaker, Dr. Pramila Karla ma'am, to deliver a session on the role of pioglitazone-based combination therapy in diabetes management in current era. Over to you, ma'am.
Thanks, Dr. Tanmay, and good evening, everyone. And thanks, Dr. Tanmay and Emcure team for the kind introduction. So I'll just be sharing my slides. 1 second. I think my slides are visible. I just have to make that full screen. Slides are visible?
Yes, ma'am.
Yeah. So good evening, everyone. And today we'll be discussing about pioglitazone because we know that pioglitazone we have been using for many years now. But in between, there were some studies which came and some meta-analysis because of which for some time we were not at all using it. But we know it is one of the very good drugs which we can use in the management of diabetes. But we have to choose the right patient. So if we have a patient who is already having some heart failure or is gaining weight, that may not be the right patient for pioglitazone-based therapy. But there are patients, especially the younger lot, who have no comorbidities, no cardiac problem. They are one of the best for the use of pioglitazone many a times when they are severely insulin resistant, because this is one of the very good drugs which can help to not only control the insulin resistance, but also control the hyperglycemia to a great extent. So my outline of the talk will be a little bit about the management and then what is the use of pioglitazone-based therapy. And then anything in medicine, when we talk about, we have to talk about the evidence and then we will summarize. Now, if you see, the number of diabetes patients is increasing day by day, and especially if you see in our country, the number is huge. And we know that the number is expected to increase to around 124 million, and now the number is even more. The projected number is even higher. So we know that whenever we talk about diabetes patients, we know that there are still a lot of unmet needs in the management of type 2. In spite of the best of treatment, first of all, we don't get the best of the glycemic control. Most of the patients hover around HbA1c beyond 8. And also, if you talk about the combinations which address the multiple pathophysiological benefits, that is also sometimes not given to the patient, or the patients don't get the benefit. The risk of CV death remains in spite of adding statins, in spite of controlling the hyperglycemia and giving multiple drugs to reduce or mitigate the risk of cardiovascular disease. And also, we also have to have more and more of oral options, because most of our patients would want oral therapy rather than injectables. Then the another thing which is always a concern in diabetes management is the weight. So we know that patients with diabetes tend to gain weight. So we need to have medications which can cause a weight neutrality or a weight loss effect. And another thing which we are always worried in patients with diabetes is the hypoglycemia. The risk of hypoglycemia is more with some of the drugs like SUs. And we know that over a period of time, when the patients develop multiple complications of diabetes like nephropathy, autonomic neuropathy, their hypoglycemia risk is even higher because their response to hypoglycemia is very poor. And also, we need to have therapies for patients which provide not only glycemic benefits, but also extra glycemic benefits as well. Now, when we talk about the management of diabetes, we know that we need to target the multiple pathophysiology, and this is evidence based. We know that now we have enough evidence to tell us that we should not just target one pathophysiology, but we should target multiple pathophysiology. If you see a few years before, we were just targeting few of the things like the decreased insulin secretion or the increased glucagon secretion, but now we know that the other things are also there, like the neurotransmitter dysfunction. There's a decrease in incretin effect, there's increased lipolysis, there is increased glucose resorption because of upregulation of SGLT2, there is a decreased glucose uptake at the level of the muscle, and there is a hepatic glucose output which is increased. So whenever we have to target diabetes management, we have to target with multiple drugs the combination of this pathophysiology so that we can give a good glycemic control to our patient. Now, when we talk about diabetes management, we know that even if the patient comes with a lower value of HbA1c at the baseline, even hovering around 7.5, we know that we start with monotherapy, but now we have data from multiple studies, including the Verify trial, where it was clearly shown that even if the blood glucose values are not very high and the HbA1c is even 6.5 to 7 at the outset, if we give multiple drugs which have the least risk of causing hypoglycemia, it actually helps the patient to have a good durability of the effect and a better glycemic control. Because if you see the data of the diabetes population the world over, the maximum problem happens in the initial 5 to 8 years when the patients are left with a higher HbA1c for a longer period of time, because the glycemic control is not achieved with a single drug in the beginning, and the patients tend to delay the addition of the second drug. And by the time they actually get to the target, they are already in that hyperglycemic range for a longer period. So that is the basic concept, that when we have a patient who comes with a higher HbA1c, we start with a dual therapy, and most of the time the dual therapy will contain metformin with one or the other first-line agent. Also, we know that if the patients come with a HbA1c which is higher than 9, then we go on for triple drug therapy. And we can also add insulin depending on if the patients have hyperglycemia, if they have some infection, or if they have some of the reason for the initiation of insulin, like they're in a catabolic state, they have ketone positivity, or they are in relative insulin deficiency, or they come with some severe infections, or they come with severe catabolic symptoms or osmotic symptoms. That point of time, we do initiate insulin for a short period, bring down the glucotoxicity, and then shift them to multiple OADs later. But many a times the patients who are not in this type of a scenario, and they are just a garden variety of type 2 who come with a high HbA1c, we initiate triple drug, oral or one of the injectable therapies with the 2 oral to control the hyperglycemia. If you see, as we are talking today about TZDs, that is thiazolidinediones, you can clearly see here when the HbA1c, even at the outset, is less than 7.5, we can have options of this as a monotherapy, but we know that most of the times metformin would be the first choice. And along with that, we add on the other drug. It would not be that we give the other drug the first, but there are patients who are intolerant to metformin. There's a small percentage of patients who don't tolerate metformin and they may need some other drug to be started as the initial first line drug. And then we already have these options. And also, in another scenario, when the patient already had a cardiovascular event, where you would give SGLT2 as a first line. So that's one indication where SGLT2 or GLP-1 would be the first line. Now, when we talk about the diabetes management, we know that we have clear cut definitions that if the patient has heart failure or a high risk for ASCVD or already has CKD, then those patients should be given the benefit of SGLT2 plus minus GLP-1 analogs. If one of the drug is not able to get the HbA1c to the target, then we have to add the other one. So if SGLT2 is added already and the HbA1c is not up to the target, we add the GLP-1. GLP-1 is already there, not to the target, we add the SGLT2. But we know that these are the mandatory requirement in a patient who comes with a high risk of ASCVD or with a renal problem or with albuminuria. These patients should be definitely offered SGLT2 and GLP-1 analogs. Now, when we talk about diabetes management, what is the major cause of non-compliance? The major cause of non-compliance is the number of medications. So patients will have not only anti-diabetic drugs, they will have antihypertensives as well. They'll have statins as well, and they will have some other drugs like for neuropathy. They may have drugs for cardiac problems. So they'll have multiple drugs. So the patients tend to miss some of the medications, and most of the times it is seen that they will tend to miss many of the anti-diabetic drugs. So that's the basic concept of going for a polypill or a FDC combination where the patients can get multiple drugs in a single pill and they don't tend to there is no non-compliance or there is no problem with the compliance. And because if the compliance is good, the HbA1c targets are met and the patients can be controlled better. So we know that if we have the drugs which are targeting the multiple pathophysiological defects, which I showed you, the ominous octet, and then the patients get multiple benefits and multiple other pleiotropic benefits as well, which will be actually beneficial for the patient. Now, coming to our question for today, which we are discussing, that is the pioglitazone-based therapy. Now, we know that the major defect, if you see in patients with type 2 diabetes, are two. One is they have a beta cell dysfunction because of which there is a reduced insulin secretion or the secretion is dysfunctional and there is a resistance. Now, when you give TZDs, that is pioglitazone, it reduces the insulin resistance, and we know it is acting via the PPR activated receptors. It also, in a way, indirectly helps in the reduction of the beta cell dysfunction by reducing the glucotoxicity. And also, we know that if pioglitazone is given along with metformin or with DPP4 inhibitors or many other drugs that can be combined, it actually helps to be a very good drug to reduce not only the HbA1c and the glucose levels, as well as the fasting plasma glucose values also. And it can be used with many other drugs. We have all used it with metformin. We have used it with even SUs and metformin combination. And we know this is one of the very good drugs which gives a good glycemic control. Now, we know that pioglitazone data is enough. We have lots and lots of evidence with it as a monotherapy or combination with metformin. And it has been also found to be better or help in improving the insulin resistance, the lipid parameters as well. And also, this is a well-tolerated drug with very less risk of side effects. As I told in the beginning, we should choose the right patient. So if a patient who has come to you with a weight gain problem or is obese, we may not offer them pioglitazone. But we have lots of patients who are normal weight or just on the border of the overweight who have severe insulin resistance, and they do benefit from the use of pioglitazone and their cardiac status is mostly fine. So we know that now what we have understood is it should be used earlier in the treatment of type 2, not when a patient comes with heart failure or cardiovascular problems already there. It should be used earlier. And we are using it in that case, those case scenarios where the patients come around, like we have patients around 30, 35, 40 who already have severe insulin resistance. They are type 2 diabetic. They don't have any cardiovascular illness. They are normal weight or just on the verge of overweight, but they're not gaining weight. And it can be used safely in those group of patients, either as an add-on to metformin. If the patient is intolerant to metformin, then it can be used as a monotherapy. Now, if you see the effects, now we have to also see the evidence. So, what? Let us see the evidence with the pioglitazone. So, what is the evidence we have? Now we know if you talk about the cardiac benefit or the cardioprotective effect, we know that it is a potent insulin sensitizer. It preserves the beta cell function. It causes a definite reduction in the HbA1c, as I told you, because of the reduction in the beta cell or the glucotoxicity for the beta cell. The beta cell dysfunction also is taken care of to some extent. It also is a very good drug for NAFLD or what we call as the MASLD. We know it is one of the drugs which all of us have used for the indication, and now we use the terminology MASLD for it. We know that with the lower doses, the effects of the weight gain and the fluid retention and the fracture and the secondary osteoporosis are reduced to a great extent. And it is definitely outweighed by the multiple benefits which we see. And we know that this is one of the very good drug, a cheap drug, which we can use for our patients for the right patient and judiciously and the correct dose. Now, if you see the various organs where the pioglitazone has a good protective effect, it has been shown to have a reduction or cause a reduction of 47% of the secondary stroke in patients with previous stroke. This data we have from the proactive. It has shown to cause a 28% reduction of the reinfarction in patients with previous MI, again from the proactive. Decreased 37% of the acute coronary syndrome after previous MI, again from the proactive. Stop the progression of coronary atherosclerosis from the periscope study. Reduction of CIMT from the Chicago data, we have got this. And reduction in the MI, stroke, and death in patients with CKD, again from the proactive. Reduction in the microalbuminuria as well from the quartet study. And reduction of 50% mortality in incident patients on hemodialysis. This was one of the smaller studies which was done. And reduction of inflammation and necrosis in NASH. This is well known. We have lots and lots of data. As I told you, now we use the terminology MASLD, but we know that we have lots of data with pioglitazone, and there is a 50% risk reduction which was seen for hepatocellular carcinoma. So if you talk about the use on the vascular system and the CV risk reduction, we know that in the coronary arteries atherosclerosis, it has been found to help in reduction of the plaque inflammation, the reduction in the neointima progression and the neointima after stent implantation, decrease in the in-stent restenosis, reduction in the LDL levels and total cholesterol, because we know that Indians have typical atherogenic dyslipidemia. They have not got a very, they will not come with a very high LDL level, but they'll have the small dense LDL, which is very atherogenic. Along with that, they'll have the low HDL. So we know that it has been found to have some better effect on the increase in the HDL. And lipoprotein A is another thing which we are seeing in lots and lots of our patients who come with very high LPL levels. So it also helps to some extent in that. It has some good effect on the endothelial dysfunction. It increases the flow-mediated dilatation and reduction in the inflammation and the oxidative stress. It reduces the aortic pulse wave velocity. It increases the body weight, but there is a redistribution of the adipose tissue. There is increased differentiation of the pre-adipocytes. There's an increased mitochondrial biogenesis, increased lipid metabolism, and increased extracellular matrix remodeling. Along with that, we know that there is some amount of fluid retention, which is because of the mechanism of action of this drug. That's why if a patient has already come to you with fluid retention, who's already having heart failure, is not the right patient for this drug. We always counsel the patient that while taking this drug, if they have some breathlessness or fluid retention or swelling, they should report to us. It also increases the vascular permeability, but it increases the renal sodium reabsorption. So that's one of the reasons why the edema and the fluid retention can happen. It reduces the blood pressure, increases the circadian rhythm. The baroreflex also is increased, and reduction of the intima media thickness progression is reduced and reduces the plaque inflammation as well. So we know that it has a very good effect on the cardiovascular functions and risk factors like blood pressure, the lipids, the adipose tissue physiology, and it hence leads to reduced atherosclerosis progression. So when we talk about on the established CV risk factors, if you see, it improves the redistribution of the fat, decreases the blood pressure, decreases the triglyceride, increases the HDL, converts to larger, more buoyant LDL. As I told you, the small dense LDL is more atherogenic. It causes a durable decrease in the HbA1c. It reduces the inflammation, reverses the lipotoxicity, improves NAFLD or MASLD, and inflammation is reduced, hyperinsulinemia is reduced, insulin resistance is improved. So we know it is one of the very good drug for insulin sensitization or improving the insulin resistance and reducing the insulin resistance and improving the insulin sensitivity. So if you see, it has a good effect on the HbA1c reduction. The risk of hypoglycemia is very low. If we all have used pioglitazone, and we know once we give pioglitazone, we are not worried about hypo until unless we use it with SUs or insulin. Then definitely there is a risk of hypo. Improves insulin resistance, improves the beta cell function. And we know it can even, if studies are there in even pre-diabetes, and the progression to diabetes was found to be reduced. It increases the good cholesterol, that is the HDL, reduces the triglyceride, reduces blood pressure, and as I showed you, the inflammatory markers as well. Reduces the microalbuminuria, decreases the cardiovascular events in high-risk diabetic patients, improves endothelial dysfunction, improves muscle. But only thing is weight gain. That is one issue. But we know that decreases the visceral fat. It is not increasing the visceral fat. It also decreases the hepatic and the muscle fat content. So that's important. The weight gain is not happening because of increasing the hepatic fat or the muscle fat, which is very, very dangerous. So actually that is reduced. The fluid retention is reduced. The heart failure is, the fluid retention happens because we saw that there is increased sodium resorption, but it can be reduced by telling the patient to follow the salt restriction, take care of the fluid intake. But also if the patient is getting fluid retention, then we have to immediately stop the drug. We normally tend to do a echo in some patients who are older, where we are planning to give pioglitazone for the risk over the for the particular benefit, but we have to check their cardiac functions before we go on to give the drug, and we normally do echo to check what is the status. Now we know that it has been also found to be associated with bone fractures, so we have to see that if it's a postmenopausal lady who is a high risk for osteoporosis, there we may not use this drug, but younger patients, as I said, we can use. We have to take care of their vitamin D and calcium status. So that way we can prevent the extra or the risk of fracture which can happen. The bladder cancer data did come up, but it was not established later. So we are only talking about a cumulative dose. So what we say is we have to use a lower dose. We don't go with like 45 mg, what we were using earlier. Now we go with 7.5 and 15 mg dose. And we try to give the benefit of the drug and not cause a harm or a risk to the patient by increase the weight gain or fluid retention or causing more risk of osteoporotic fractures. And with that lower dose, we can use it for a longer period. So the cumulative dose turns out to be lesser. So the risk of bladder cancer and other things definitely comes down. So we know that it is one of the very good drugs for cardioprotection, but we know that because of so many things which came up and the risk of bladder cancer, the use came down drastically, because previously we were even using it much more, but we got skeptical about its use. So what we have learned from the new data now, that we have to use it in a lower dose, choose the right patient and follow up the patient, and then take a call. And cumulative dose is more important rather than we worrying about using a 7.5 or a 15 mg dose. So we know that it is one of the good drugs which can be used in combination therapies, because it not only improves the CV outcome, but also obviously we have seen it reduces the stroke incidence. It has been found to reduce the CV risk. It has been found to have a good effect not only on the HbA1c, but also to some extent improvement in the beta cell dysfunction. And as I was talking about, that it is a very good drug for MASLD, or what we used to call NAFLD. And we know that it can be also used with the drugs which don't have a tendency to cause weight gain. So when you are using it for diabetes, we use it with metformin, where pioglitazone is one of the good drugs, because then metformin does not normally cause weight loss, but it is not going to cause weight gain for sure. And some amount of weight loss may happen. DPP-4 inhibitors are mostly weight neutral, so it can be safely used with these type of drugs where the other drugs are not causing too much of weight gain. So whenever we are talking about any anti-diabetic medications, we can combine it with metformin. We can combine it with DPP-4 inhibitors also. DPP-4 inhibitors are also one of the good drugs to help in beta cell preservation. And we know that it can be used along with the pioglitazone, and DPP-4 can be used as one of the drugs for the patients to have a good effect, not only on the hyperglycemia, but also to have some extent good effect on the beta cell dysfunction as well. Now, we know that if we normally use it with metformin also, and we know that it has a good effect and a beneficial effect in the metabolic risk factors, as well as the various risk factors for the cardiovascular disease, as well as a good effect on the hyperglycemia control. So when you talk about the complementary mechanisms of action of the TZDs, that is pioglitazone and metformin, it can be used as a combination therapy. And it is not only going to give the anti-hyperglycemic effect, but also the metabolic risk is reduced, as well as the cardiovascular outcome of the patients are also reduced. Now, coming to the clinical evidence, now we have to also see that what are the clinical evidence, because we have talked so much about the use of this drug. So, where all do we put it into practice? Now, if you see the clinical evidence, we know that if you see the use of pioglitazone based therapies, it has been definitely found to improve the insulin sensitivity. It has been found to also have a better effect as compared to the gliclazide based regimen. So, we know that if you talk about SU's comparison with pioglitazone, it will definitely score higher because it has been found to have a very good effect on reduction of insulin resistance and improvement in the insulin sensitivity. And this is definitely important in the management of cardiovascular risk in patients with type 2. Also, if you see the combination therapy of metformin and pioglitazone, it has been found to have a definitely better effect on the reduction of the insulin resistance and the improvement in the insulin sensitivity, as well as we know that the changes in the was similar in the insulin resistance with dapagliflozin in overweight individuals with type 2 diabetes. So if you see the comparison of metformin pioglitazone combination or comparison with dapagliflozin, it was almost found to be similar. We know that we need to have longer data and longer follow-up data to comment on that. But what we have understood is it is comparable even with the SGLT2 inhibitors. So we are not trying to say that we should not use the SGLT2 inhibitors, but definitely this is a comparable drug which can be used in the right patient, because there are some patients where there may be contraindication to the use of SGLT2 inhibitors. You would not want to use SGLT2 inhibitors, and definitely not in the heart failure group, because there we are not talking about the use of pioglitazone, but we are talking the use of pioglitazone in a younger lot who has come with severe insulin resistance, is normal weight or overweight and not like obese, and has not got any cardiovascular comorbidity. Those are the right patients to use these drugs. Also, we have data of the combination studies on the HbA1c reduction. This was shown over a period of 24 weeks, where the combination therapy as an add-on to metformin and the drugs have been used, and we know that it has been found to have a very good effect on the on the reduction of the HbA1c. So if you see, the placebo use was there in 224 patients and sitagliptin use was there in 453 patients. So you can clearly see here, as an add-on to metformin and as an add-on to pioglitazone, you can clearly see here again it is placebo and sitagliptin comparison. If you see placebo at 174 and the sitagliptin patients were around 163. So if you see the combination studies and for the study with the like pioglitazone in the right panel, you can clearly see that there was a very, very good reduction with the other drugs as well. So we know that the change in the HbA1c, if you see here, was around 0.7%. So that's also very important because it has been found to have a good effect on the HbA1c reduction. Now, if you see this study was done to see the effect of the DPP-4 inhibitor in combination with metformin, that is more than 1500 milligram per day, and pioglitazone more than 30 milligram per day in patients with type 2 who were having an inadequate glycemic control, which was defined as HbA1c between 7.5 to less than 11. So they took patients who had a mean HbA1c of 8.7. This was a multinational randomized placebo-controlled double-blind parallel group 26-week study. They were either randomized to receive sitagliptin 100 mg or placebo for 26 weeks, and they were trying to see the change in the HbA1c after 26 weeks of treatment. So this therapy was like this. You can clearly see here that used the full dose of sitagliptin in a patient who have been having a combination therapy of metformin and pioglitazone. So basically, they were trying to see the efficacy of this, and they were also trying to see the safety of this. So what they found that when the sitagliptin was added to the ongoing combination therapy of metformin and pioglitazone, you can clearly see the HbA1c reduction happened again. And the triple combination was well tolerated. That was the most important thing, because we are always worried if with pioglitazone, metformin, DPP-4 we add, what will happen? So there was very low incidence of hypoglycemia. No meaningful change in the body weight happened versus the dual combination therapy, which was already on with metformin and pioglitazone. So this was also one of the studies to see the efficacy of dual anti-hyperglycemic combination therapies in patients with type 2 and find out the most efficient and the effective method. So they took 160 patients with type 2. Again, HbA1c is between 8 to 9.5 and who were actively treated with metformin. So this was the study done over a period of 12 weeks where they compared 100 milligram of sitagliptin and pioglitazone 30 milligram in type 2 diabetes patients whose disease or the glycemia was not adequately controlled with metformin alone. And obviously, they were trying to see the mean change in the HbA1c. And what they found that sitagliptin and pioglitazone demonstrated similar improvement in the glycemic control in type 2 whose blood glucose levels were inadequately controlled with metformin. So they found that it was similar, but sitagliptin was more effective than pioglitazone regarding the body change. So that's expected because we know that there will be some amount of weight gain. I showed you the data. There'll not be increase in visceral fat, neither there will be increase in pancreatic and hepatic fat. So that data I've already showed you, but there'll be some amount of increase in the fat. So weight gain will definitely happen. So again, they were trying to see the triple oral therapy between metformin, pioglitazone, and sitagliptin. And the other one was metformin, pioglitazone, and glibenclamide. So they took around 476 patients who were uncontrolled. Again, it was a multi-center study. And they were trying to see the HbA1c variation and the beta cell function management. Now we have to understand that we don't use glibenclamide anymore now. We use the newer sulfonylureas like gliclazide and glimepiride. Glibenclamide has been mostly off use and we don't use it in our patients anymore. So what they found that definitely sitagliptin was found to be better, which was expected because sitagliptin will have a neutral effect on the body weight and it will not have a propensity to cause hypoglycemia as well, as much as glibenclamide. And anyways, it is, as I told you, this sulfonylurea is not used anymore. So we have to see that patients, this was another study where patients were already treated with the pioglitazone and metformin, and this was a 3-year study. So they were trying to see that if triple oral therapy can be used in improving the glycemic control compared with metformin monotherapy or metformin and pioglitazone combination. So they found that when double therapy is not enough to reach the glycemic control, sitagliptin, basically what we are trying to understand is DPP-4 inhibitors have been found to be quite safe, like sitagliptin, can be preferred to sulfonylureas as a third agent because we know that it has a good effect on the beta cell function and the risk of hypoglycemia is very less. And SUs will cause some amount of weight gain, which will not happen with DPP-4 inhibitors because DPP-4 inhibitors are mostly weight neutral. So this was also another study where they were trying to see that the advanced glycation end products formation, and they definitely found that the pioglitazone treatment was found to have a better effect on the disease progression indicators like advanced glycation end product formation. So this is another important thing because they found that this risk factors were reduced independent of the glycemic control. When they were using, then they found that it was found with both pioglitazone and glimepiride. So basically what we have understood is pioglitazone achieved a greater benefit. Like they found that the benefit was better in the reduction of the oxidative stress with pioglitazone. And we have understood this very nicely from the mechanisms which we saw in the previous slides, that if you have pioglitazone, you are actually reducing the inflammatory markers, you are reducing the endothelial dysfunction, you are reducing the reactive oxygen species, and in a way, you are actually giving a better benefit with regards to the cardiovascular outcome. We have the data from the proactive study where we saw the reduction in the stroke and the cardiovascular events as well. So when we talk about the use of pioglitazone in type 2, we know that it can be used, and we have data with sitagliptin and pioglitazone. They found there was a good reduction in the HbA1c. We have a data with the triple therapy with the pioglitazone and sitagliptin added, and it has been found to be better as compared to adding a glibenclamide in place of sitagliptin. Also, we have understood that it has been found to have a better effect on the beta cell dysfunction, and also improvement in the beta cell function happens, insulin sensitivity improves. Again, we have data with the 54-week extension period for sitagliptin pioglitazone combination, and they found here the HbA1c reduction to the tune of 2.4% with the sitagliptin 100 mg, and pioglitazone they used a higher dose 45 mg. Now we are mostly using a lower dose of 1.5, 7.5 or 15 mg. Maximally 30 we are going, 45 we are not using much in our patients. But they found that when this was combined, it was a 2.4% reduction versus 1.9 with the pioglitazone 45 mg monotherapy alone. So this was a 54-week study, and they found that the initial combination therapy, as I was discussing, that we are now targeting diabetes early. So we say hit early and hit hard from the beginning. So we should not be doing it at the end when the patient has already developed the complications. A lot of times the patients will come to us and they will say that I have renal failure. Now you control my glycemia to 100. That won't be of any use. We have to do it from the beginning. So we have to hit early and hit hard. And that is how this study showed us that if you give the combination therapy of the pioglitazone and sitagliptin, it was found to be well tolerated and it was found to be quite durable. And there was a good improvement in the glycemic control. And the similar thing we have seen from the Verify trial, where vildagliptin metformin combination fared much better, and the patients had a better glycemic control and more durability of the effect as compared to the use of the only one drug at the baseline. So we also have found that monotherapy versus the combination therapy, if you see, it was obviously the combination therapy if you use. If you target multiple pathophysiology, we can have a better HbA1c reduction, better fasting plasma glucose reduction as compared to monotherapy. And they did not find any further risk of hypoglycemia with the combination therapy or any more AEs. And there was a better improvement of the pancreatic cell function. So this was another thing they found that this was one of the Korean studies where they tried to see the pioglitazone or DPP-4 inhibitors in drug-naive Korean patients with type 2 diabetes. And they found that the patients who achieved the HbA1c less than 7% at 24 weeks, and they were trying to see that whether metformin or gliclazide or glimepiride, they took one group of metformin and either gliclazide or glimepiride, and they took the other group as metformin and pioglitazone, and they took another group as metformin and sitagliptin. So they found that combination therapies of metformin and either SUs or pioglitazone or sitagliptin actually showed a similar glycemic effectiveness amongst the drug-naive Korean patients with type 2, and they were similarly effective across a wide range of HbA1c levels. So they had three categories. As I told you, one was a sulfonylurea group, one was a pioglitazone group, and one was a sitagliptin group. So also, if you see here, the patients who the successful diabetes control, if you try to see again, you can see the proportion of individuals who had a successful diabetes control. Again, you can see 7.5%, less than 7.5% HbA1c. Then we have the category 2, where they again in the category 2 they had tried to see HbA1c from 9 to less than 9% to less than 11%, and the category 3 also they have tried to see, and they have found that the patients did have a good glycemic control, and all the three groups did not show a statistical difference. So if you see, either we add metformin with SU, we add metformin with pioglitazone, or we add metformin with sitagliptin, it was found to be equally effective for a successful glycemic control in drug-naive patients with type 2 diabetes. Now, this is the most controversial thing, because of which we know that it went out of the use for some time. And we know that this was one of the studies which came, and then there was a lot of commotion which happened, and the drug was banned for a small period of time. So we know that the bladder cancer incidence is not very high in our country. The Americans, we know, have a higher relative percentage of suspected bladder cancer. Metformin is having and has been shown to have some anti-cancer potential. And actually, if we are using metformin and pioglitazone, we may be indirectly helping by reducing the risk of any of the cancers. We know metformin has anti-aging, anti-cancer effect as well. Now, we know that there were a lot of this data or the meta-analysis which had come out was because of many studies where there were a lot of reporting which happened. So whether it was actually related to the drug or not, that also we are not sure. So we know, as I was talking about, there is a cumulative dose. So normally we don't try to cross this cumulative dose of 28,000 milligram, which corresponds to an average dose of pioglitazone around 40 milligram per day. The dose they use in their country is around 30 to 45. And as I said that in India, we mostly use less than 30. And now we are using lower dose, 7.5, which would take about 10 years to reach this cumulative dose. So that is what we do. We use around 7.5 to 10 mg, 15 mg dose. And to reach this 28,000 milligram cumulative dose, it will take a longer time. And we know that lower dose of pioglitazone has become quite popular in our country because it's efficacious. It works well for our population, and it has a lower frequency of side effects like weight gain and fluid retention, which is seen with 30 mg and 45 mg dose. So as I told you that the pioglitazone has a good effect on many of the factors of the ominous octets. and it has a good effect on the making the insulin secretion better by reducing the glucotoxicity, improving the beta cell function, and we know it has a very good effect on the control of the hyperglycemia and also the reduction in the oxidative stress markers, because of which the patient's glycemic control becomes better. The tendency for the patient to develop multiple complications because of the reduction of the stress, because of reduction of the formation of advanced glycation end products becomes better. And we know that it has a good effect on the dyslipidemia as well, where the triglycerides are reduced, the HDL is increased, and the LDL becomes larger, which is less atherogenic. So, if you talk about the combination therapies, we know that DPP-4 inhibitors definitely work on the incretins. We have the DPP-4 inhibitors, and metformin and TZDs do work on the decreased glucose uptake. We again have their effect on the insulin resistance and the hepatic glucose output. We know that DPP-4 inhibitors also work on the glucagon, which is secreted more. We also know that metformin TZDs work on the increased lipolysis. And we also know that DPP-4 inhibitors have a good effect on the hepatic glucose output dysfunction as well. So the multiple therapeutic options added for the treatment of type 2 and leading to the control of the multiple pathophysiology actually helps to manage diabetes better and gives a better glycemic control for the patient. Early use of targeted therapy is actually the best way out, because that is what we have learned from the multiple evidence which have come through. Hit early, hit hard, and hit correctly also. So we should not try to give therapies which cause hypoglycemia. Like suppose we add high dose of SUs in the beginning, the patient may get a hypoglycemia, and that's not safe for the patient. So we should use drugs which have a lower propensity to cause hypoglycemia. Target the multiple pathophysiology gives a better durable effect to the patient, and that can be more individualized treatment for many of the patients, especially as I said, can be offered to younger patients with no comorbidities, more insulin resistance, not very much obese, like normal weight or lean side or borderline overweight. They can benefit better from the use of TZDs. So we know that metformin, pioglitazone, and sitagliptin combination can be one of the best combinations to control the hyperglycemia in the right patient. They act on different pathophysiologies, as I showed you. They target the ominous octet together, and some of the beneficial effects are there. There will be some effects on the weight gain, but mostly that will be mitigated by the use of metformin and DPP-4 alongside with that. And we can use early combination therapy, especially in patients where the HbA1c to start with is higher. We can start off with a single drug, but over a period of time, we know that if we delay the initiation or we delay the intensification, the patients can get more complications. So I think with this, I end and we can take the questions.
Thank you, ma'am, for the insightful presentation. We will now take up the questions from the audience from the chat box. So I can already see a few questions in the chat box. What?
So yeah, first question is, when HbA1c is more than 9 amongst all the triple combination Sita Dapa Met, Sita Glimepiride Met, Sita Met Pio, which is the best, right? So as I said, we have to individualize the approach. Now, if you have I'll give you 2-3 case scenarios. Now, if you have a patient who is obese and who has come with the hyperglycemia, HbA1c of 9.5, obese, not beyond 11, 10 or 11, because there I would not use SGLT2, but initially, I'll bring down the glucotoxicity and then add. There I may use sitagliptin, metformin, and glimepiride maybe, bring down the glucotoxicity and then maybe replace glimepiride with dapagliflozin and continue the sitagliptin, metformin. But if I have a patient who is lean or normal weight and who has come to me who is severely insulin resistant, I would be comfortable in giving pioglitazone, metformin, and sitagliptin in that particular patient, because there I would not like to give gliflozin if there is no indication particularly. In an obese patient, I would particularly give it for weight loss benefit. I would not give it with a very high HbA1c of 10 or 11 initially, the SGLT2, because the risk of genital infections will be higher. So in that case scenario, I will go with sitagliptin, SU, and metformin in the beginning, bring down the glucotoxicity, and later on replace with the dapagliflozin. But in a patient, as I told you, normal weight or borderline overweight or lean, I may be comfortable in a higher HbA1c with insulin resistance. With a typical case scenario of type 2 diabetes, I would be comfortable in giving even sitagliptin, metformin, and pioglitazone combination. Would pioglitazone-based therapy be preferred in patients with NAFLD? Yes, definitely, definitely. Now we use the new terminology, as I said, MASLD. Pioglitazone is one of the good drugs for control or for the fatty liver and for MASLD. It would be one of the best therapies which I can offer to these patients. Until and unless, as I said, that if a patient is obese or gaining weight or too much overweight, where I would like to weight loss, losing drug to be added, I may not go for it for those patients, but it is one of the very good drugs which we use for muscle. So if my patient is normal weight or lean or mildly overweight, not gaining too much of weight, not on the obese category, I would be comfortable using a pioglitazone based therapy in these patients. And that is the advantage of pioglitazone, because pioglitazone has lots and lots of data in muscle, and the DPP4 inhibitors have been tried and have been found to be beneficial in muscle. So we can also add on the DPP4 inhibitor, but that is for a patient who is having diabetes, not otherwise. Not like if a patient is non-diabetic. Then I won't add a DPP4 inhibitor. And then the question is how to differentiate all three triple combination in terms of patient profiling. So I think I discussed a little bit about the patient profiling. So if you have an obese or an overweight patient or a patient gaining weight, we don't go with pioglitazone as the first choice. We'll use sitagliptin, maybe metformin, and SGLT2 would be my choice. But if a patient who is normal weight or borderline weight or borderline overweight or lean, is severely insulin resistant type 2 diabetes, pioglitazone can be one add-on with the DPP4 and metformin. I can safely use it. And a very high HbA1c, I would not go with SGLT2 also. There, either I will offer insulin, patient is not ready for insulin, I normally go for DPP4, metformin, and glimepiride or gliclazide combination. And can this combination be preferred in obese patients? See, obese, I'll be a little bit skeptical, but there are cases where they are severely insulin resistant, where what we do is we use a low dose of pioglitazone of 7.5 to 15 mg. We don't cross the 15 mg mark. So we use 15 mg, we don't go with 30 mg, because if you go with 30, they'll gain weight and that may not turn out to be a beneficial effect. It may turn out to be more problematic for the patient. Patient may gain 4 5 kgs of weight. So in such patients, if we have to use for the patient and we think that the patient is severely insulin resistant, will benefit from the use of pioglitazone, we go with a 7.5 or 15 mg with the other drugs. So actually that will sometimes help the patient. So that's how we use it.
So, ma'am,
Then
other
there is
than
a
that, there was
question.
just one question remaining. What is the best way in routine practice to check for insulin resistance?
See, routine practice, there's no need to do a HOMA-IR or a fasting insulin and glucose value and calculate. The best way is the patient's examination. So if you have a patient who has severe acanthosis nigricans, overweight, not even overweight, even if they are lean, they have abdominal obesity, they have acanthosis nigricans in the neck. If you don't find it in the neck, see the axilla. They may be having it in the axilla. They will have skin tags. These are the patients who are the ones who are insulin resistant. So we don't, and you will see that they'll be responding nicely to metformin. So these are the typical patient profiles which are the clinical markers of insulin resistance. We don't need to do HOMA-IR and other things. This, by clinical examination itself, we can get to know that this patient has severe insulin resistance.
So I think those are all the questions. So we are nearly at the finish line. But before we conclude, let's express our gratitude to all those who made this program possible. For this, I would like to invite Mr. Ajay Godke, Marketing Head, Nusurge Emcure, to give the vote of thanks. Over to you, Mr. Ajay.
Thank you, Dr. Tanmay. And I sincerely would like to thank you, ma'am, Dr. Pramila Karla, ma'am, for the excellent talk. And indeed, it's pleasure to be a part of this program. Emcure is always a research-driven organization and always believe in terms of science. So for the newer combinations like pioglitazone, sitagliptin, and metformin, we really enriched with the knowledge that you have provided, you, ma'am. And we have a lot of such programs for audiences that are going to come in the near future also, where we will require such kind of guidance. So really, thank you, ma'am. The talk that you have provided, especially like hit early, hit hard, and the safe use of pioglitazone, it's really important for everybody to understand in coming days. So really, thank you. Uh, and we look forward for such kind of programs in coming days.
Thank you. Okay, good night, everyone. Then,
ma'am, it was really a wonderful session, and your flow went quite well, and you spoke excellently. So thanks
you.
for being on the board of Emcure, and we are really grateful to have your presence. And
Thank
thank you
you.
very much. Thank you very much. It was wonderful to listen you. Thanks a lot.
Thank you.
Yeah.
Especially
night,
the
everyone.
studies and I think the clarity that you have provided was really good, ma'am. I think you have taken a lot of different cases, the severe risk cases and other cases where it will really help.
So thanks everyone and good night.
Thank you, ma'am. Bye. Good
Thank
night.
you, ma'am.
Emcure.
Thank you,
Yeah,
ma'am.
thank
Thank
you.
you, ma'am.
Thank you,
Good
Dr.
night.
May.